Good afternoon. I'm Kathy Lepick, presenting on behalf of our research team at the BC Centre for Excellence in HIV/AIDS. Today we are sharing our work on declining prevalence of drug interactions between antiretrovirals and other drugs in ART-treated persons in British Columbia between 2010 and 2016. I have no conflicts of interest to declare. This study uses data from BC's Stop HIV/AIDS cohort. All inferences, opinions, and conclusions drawn in this presentation are those of the authors and do not reflect the opinions or policies of the data stewards. We acknowledge with great thanks the experts who maintain the HIV drug interaction websites published by the Immunodeficiency Clinic at the Toronto General Hospital and the University of Liverpool. These resources are used in our clinical practice and were also used for classifying the drug interactions in this study. Drug interactions between antiretrovirals and other co-prescribed medications are potentially harmful and can lead to increased toxicity or loss of effectiveness of either the ARV or the other medications. In recent years, there has been a shift from NNRTI and protease inhibitor-based regimens towards integrase inhibitor-based regimens. This could possibly lead to changes in the drug interactions observed in persons receiving ART. The objective of this observational study was to characterize the possible changes in prevalence of interactions between antiretrovirals and other drugs during a period of evolving ART prescribing patterns. First, we compiled a list of all medications dispensed to ART-treated persons between 2010 and 2016 using data from the Stop HIV/AIDS cohort. This dataset includes province-wide ART dispensing records from the BCCFE drug treatment program and all other medication dispensing records from BC PharmaNet. We evaluated potential drug interactions for approximately 18,000 theoretical combinations of the 27 antiretrovirals and more than 600 other medications dispensed during the study period. Boosted ARVs were classified separately for ritonavir and cobicistat combinations. Drug interaction classification was done by experienced HIV clinicians using the categories avoid, meaning the drug combination is not recommended, caution, meaning the drug combination requires special precautions such as dose spacing or dose adjustment, and no interaction, meaning the drugs may be used concurrently in the usual doses. ARVs were then categorized by pharmacologic class, and we calculated the proportion of all 685 co-prescribed medications having a caution or avoid drug interaction with at least one ARV in each category. Ritonavir or cobicistat boosted ARVs, unboosted PIs, older NNRTIs which induce hepatic metabolizing enzymes had drug interactions with approximately 1/3 to half of all other drugs prescribed within the study period and were classified as having moderate to high risk drug interaction potential. ARVs with lower risk for drug interactions included all NRTIs such as abacavir and tenofovir, unboosted integrase inhibitors, and the newer NNRTI, rilpivirine. We then identified the combinations of ARVs and other drugs that were actually prescribed concurrently for each ART-treated patient. In each calendar year, we created time arrays of ARV exposure. Then identified co-prescribed medications where the dispensing date fell within a period of ARV exposure. Each co-prescribed drug combination was matched to the predefined drug interaction classification and counted once per person per calendar year. The study outcome was the proportion of ART-treated persons who had at least one caution or avoid interaction. In all, there were 9,035 ART-treated people who were included in the study. 83% were male, and more than 85% received co-prescribed medications. Between 2010 and 2016, the number of ART-treated people increased from 6,000 to 7,500, and the median age increased from 47 to 50 years. The proportion of people with any caution or avoid drug interactions significantly declined from 76 to 61%. Proportion of avoid drug interactions also declined from 4.9 to 2.8%. Antiretroviral usage evolved over time. The use of ARVs with moderate to high drug interaction potential declined, although from 2013 onwards there was increased uptake of the boosted integrase inhibitor alvategravir. The use of ARVs with lower drug interaction potential increased, particularly following the introduction of the integrase inhibitor dolutegravir in 2014. Overall, the proportion of people who had a regimen including any ARV with moderate to high drug interaction potential declined by 18% over the study period. Looking more closely at the observed drug interactions, we see that the ARVs which theoretically have higher drug interaction potential were indeed associated with more drug interactions. 70 to 80% of people treated with a protease inhibitor experienced at least one caution or avoid interaction with the PI. Conversely, relatively few drug interactions were associated with the unboosted integrase inhibitors such as dolutegravir or raltegravir. Looking at the subset of people who experienced avoid drug interactions, protease inhibitors and alvategravir cobicistat were associated with the highest prevalence, and the unboosted integrase inhibitors had the lowest prevalence. Rilpivirine, which overall has relatively few drug interactions, does have some contraindicated drug combinations, and these were observed. Taking a closer look at real-world prescribing of drug combinations which should generally be avoided, the top three categories were: tied for third place, accounting for 10 to 15% of avoid drug interactions, estrogen-progestin products used for contraception, which are particularly important drug interactions for women, central nervous system drugs, particularly anticonvulsants phenytoin and carbamazepine, and older sedatives such as barbiturates and triazolam. In second place, accounting for about 1/4 of avoid interactions, gastrointestinal drugs, including proton pump inhibitor interactions with unboosted atazanavir and rilpivirine, and interactions between boosted ARVs with the drug domperidone. And by far the greatest prevalence, accounting for approximately half of all contraindicated drug combinations throughout the study period, interactions between boosted ARVs and inhaled corticosteroids. With 9,000 participants, this is one of the largest drug interaction studies to date, and thanks to the BC healthcare system, we had access to longitudinal complete prescription data for both ARVs and non-ARV drugs. However, because the available data range ended in 2016, we could not include some of the newer ARVs such as bictegravir or tenofovir alafenamide. ARV drug interactions with non-prescription medications are underestimated, and this administrative data set does not permit assessment of clinical outcomes associated with drug interactions. In conclusion, the prevalence of drug interactions between ARVs and co-prescribed medications is declining in recent years, and this decline appears to be aligned with a shift towards using ARVs with lower drug interaction potential. Drug interaction monitoring remains an important part of patient care. In 2016, approximately 2/3 of our treated patients had at least one drug interaction, and about 1 in 40 were prescribed a drug combination which should be avoided. Although ARVs with lower drug interaction potential may reduce risk of interactions, ART regimens must be individualized with consideration of all clinical factors, including drug resistance and tolerability. Thank you, and we will gladly answer questions directed to the email addresses on slide 1.